Good evening. My name is Jackie Gordon, and the title of my poster presentation is Postoperative Glycemic Control in the Cardiothoracic Surgery Patient. Nearly 500,000 cardiac surgeries are performed each year in the United States. All patients undergoing cardiac surgery are at risk for hyperglycemia. Hyperglycemia is defined as a blood glucose greater than 200 milligrams per deciliter. Patients with a preoperative diagnosis of diabetes have a predisposed risk for developing hyperglycemia as a result of the inability of the pancreas to produce adequate amounts of insulin or dysfunction of the pancreatic beta cells. Both patients with and without a diagnosis of diabetes are at risk for hyperglycemia because they're undergoing surgery. And during surgery, there's a surgical stress response. During the stress response, hormones are released: glucagon, epinephrine, cortisol, and growth hormone. In addition, there's an increase in cytokine concentrations. The hormones and the increase in cytokine concentrations cause a surge of glucose production in the liver. And because there is a surgical stress response present, there's decreased peripheral uptake of the circulating glucose in the blood, resulting in hyperglycemia. This hyperglycemia has been associated with poor clinical outcomes. Clinical outcomes: hyperglycemia in the postoperative cardiac surgery patient that have been associated with this hyperglycemia are surgical site infection, intensive care length of stay that's increased, and even death. So to combat this hyperglycemia, the use of continuous insulin infusions is standard of care. In 2009, the Society of Thoracic Surgeons published guidelines to recommend that we should maintain blood glucoses less than 180 milligrams per deciliter in the first 24 hours following cardiac surgery. However, this is a much more liberal glycemic target than previously published guidelines developed based off of landmark studies that found that tight glucose control, maintaining blood glucoses less than 120 milligrams per deciliter, provided patients with optimal outcomes. Vandenberg and colleagues enrolled 1,500 critical care patients, 65% of which were cardiac surgery patients, in a randomized control trial, and found that there was a significant difference in mortality, where 8% of those in the liberal group died compared to only 4% of those in the strict group who died. However, all patients in this study were receiving a continuous infusion of dextrose concomitantly with the insulin. Later, in 2009, the NICE Sugar trial was published, which enrolled greater than 6,000 patients, fewer of which were cardiac surgery patients, but they found that those in the strict group were 1.14 times more likely to die versus those in the liberal glucose group. So the optimal target for blood glucose to prevent negative outcomes remains unclear. So this leads me to my PICO question. In postoperative cardiac surgery patients, does a postoperative insulin protocol with the goal of maintaining blood glucose levels 140 to 160 milligrams per deciliter compared to an insulin infusion protocol with the goal of maintaining blood glucose levels 100 to 140 milligrams per deciliter decrease the incidence of hypoglycemia, defined as less than 70 milligrams per deciliter, without increasing surgical site infection, ICU length of stay, and mortality? To answer this question, a literature review was performed. Search terms including glucose, cardiac surgery, postoperative, insulin, surgical site infection, intensive care, length of stay, mortality, and adult were included. Studies were only included that were published in the English language, were published from 2005 to present, Landmark trials were also included prior to 2005, and only publications that were published in peer-reviewed journals. Studies were excluded if outcomes of surgical site infection, ICU length of stay, and 30-day mortality were not reported. Databases used in this review were CINAHL, PubMed, and Cochrane. A total of 168 articles were returned, and 20 articles were selected and evaluated in depth and critiqued for level of evidence and quality. The levels of evidence most appropriate to answer the PICO question are randomized controlled trials and large cohort studies. Meta-analyses and systematic reviews retrieved were hand-searched for primary resources. And again, a landmark randomized controlled trial that included patient populations other than cardiac surgery patients was also included in this review. As you can see depicted on the poster, a table representing outcomes synthesized from the studies is presented. Of interest, hypoglycemia was found to be increased in those receiving a strict protocol. The incidence of hypoglycemia throughout the trials varied. However, across all studies, it was found to be increased in those receiving a strict protocol. When synthesizing the results of the literature, outcomes of surgical site infection, intensive care length of stay, and mortality were found to be equivalent whether a patient was receiving a strict glucose protocol or a liberal glucose protocol. So in conclusion, patients who were receiving strict glucose protocols were found to have a greater incidence of hypoglycemia when compared to those receiving a liberal glucose protocol. And when comparing outcomes of surgical site infection, ICU length of stay, and mortality, outcomes were equivalent when comparing those receiving strict protocols and liberal protocols. There were, however, significant gaps in the literature. First and foremost, it was very difficult to categorize protocols into strict and liberal categories because glucose targets range widely. So strict in this review and synthesis of these studies is considered 80 to 160 milligrams per deciliter. And liberal targets is considered 120 to 200 milligrams per deciliter. As you can see, strict and liberal glucose targets overlap throughout the studies, making it very difficult to draw conclusions. In addition, the exact continuous insulin infusion protocol used to maintain strict or liberal glucose targets and how long patients were actually achieving these targets was reported in few studies. And finally, insulin infusion protocols are generally nurse managed, and there can be user error. And throughout all of the studies, adherence to the strict or liberal insulin protocols by frontline staff was not reported. So as a result of this study, I did find that hypoglycemia is increased when patients are receiving a strict protocol. And because outcomes of patients were found to be equivalent, revision of continuous insulin infusion protocols with strict glycemic targets in the cardiac surgery patient population is warranted to provide equivalent outcomes and decrease the incidence of hypoglycemia. Further research is needed further randomized controlled trials using the exact same glucose targets to determine what the optimal glycemic target is for postoperative cardiac surgery patients. And finally, explicit protocols used, adherence to protocols, and time within target glucose range needs reported in future studies to enable implementation in the practice setting. Thank you for listening to my poster presentation.